Okay, so we are live on politics on the pub website. Let me just check that we're all coming through. See, yeah. Yes, we can see we're waiting. That's good. Peter, can you speak to us for a second?
Sure. Welcome to this special event for Politics in the Pub tonight.
That's lovely. Thanks enough. That's enough. Okay, Peter, I'm going to start the credits now.
Okay.
And all right, so. Five, 4,
3, 2. Welcome to this special event for Politics in the Pub tonight. My name is Peter Murphy from the Sydney Politics in the Pub Committee. This session was organised by Kathy Vaughan, who is managing the technical support tonight. Our regular Tuesday evening program is on this coming Tuesday at 6 p.m. sharp, also online. Now, I acknowledge the traditional custodians of the land on which we are tonight, wherever we are, including the Gadigal people of the Eora Nation on whose land I am residing. Their lands were taken, never ceded. Our topic tonight is ending quarantine, mental health of citizens and health workers. Now, Sydney has ended the curfew in those local government areas of concern and will end its lockdown when a 70% vaccination rate has been reached. But they say they will maintain other health measures after that. A careful balance must be struck between freeing Sydney's stir-crazy citizens, rebooting businesses, and keeping the COVID outbreak under control, with health services and health workers already under pressure and ICU space filling up now. Our speakers tonight are Dr. Arthur Chesterfield-Evans, a medical practitioner, epidemiologist, a former surgeon, and a former New South Wales Upper House MP for the Australian Democrats, and Professor Ian Hickey, co-director, Health and Policy at Sydney University's Brain and Mind Centre. We are going live to the general public through the Politics in the Pub and the Consortium News websites. You can send questions and comments anytime by using the chat function in the YouTube channels there. We may also have a small audience with the speakers and the tech team in the Zoom room, maybe not. But if they are here, they would be able to put their questions live. Our speakers will each present for up to 20 minutes each, and then we would have the Q&A and aim to finish at 7:15 p.m. or when the questions run out. So now I'd like to ask you to welcome Dr. Arthur Chesterfield-Evans, our first speaker. Please go ahead, Arthur.
Hi, sorry about that. Phone just rang. Should turn it off. My background was in surgery, and then I went into occupational medicine. So I've done some epidemiology postgrad and and written some papers, but I wouldn't call myself an epidemiologist as such. I'm a GP. I'm not at the front line with COVID, but I am in general practice, and I do keep in touch with what's going on. I did quite a lot of intensive care years ago, and interestingly, they're all writing and offering me fortune to go back. So there's a horrendous shortage of people in intensive care, and it's getting worse. As far as mental health is concerned, I set up the mental health inquiry in 2000, the New South Wales Mental Health Inquiry. So I was part of that, and of course I was pushing to get it set up, and I think that had a reasonable effect, although it did just show how inadequate the services were. And each mental health inquiry, which happened about every decade, said the same things, that, you know, it wasn't good and it isn't good. It's very hard to get patients into hospital now, as it always has been, and mental health is a very neglected area. I do think, though, that if you want to do preventive mental health, you give people jobs and you pay them when they're injured, and you give them physical treatments, and you give them hope, and you give them housing, and you treat them with respect. So the idea that simply letting them come out of their houses and roam free into a COVID epidemic will somehow help their mental health, I think is the last refuge of a scoundrel, quite honestly. I just think that the sudden interest in mental health from the corporate sector, who have never shown any interest in it before, is just them trying to get the place unlocked. That's my perspective on it. And I guess the other thing I do know about is a bit about politics, having been in Parliament for nearly 9 years. So I suppose I'm trying to give a perspective of all four areas: GP, epidemiology, politics, and mental health. And I'll certainly defer to Ian on the mental health side, at least. I think we have to look at the health system as a whole, and I think that is really a big problem that this is exacerbating, and it's being covered up by huge amounts of money being thrown at it. If we look at the Australian situation, we have a huge imbalance in finance between the states and the federal. The federal government gets all the money and the states deliver the vast bulk of the services. The federal government's actually not capable of delivering most services. Centrelink's a pretty bad example of how inefficient they are. But that's why they have to call in the army, because they really don't have any troops, so to speak. They don't have anybody on the ground. It relies on the states. And they have basically balanced their budgets by squeezing the states. So the states are always trying to deliver services and are very poor. Now, this is particularly the case in the health area, where federal and state both have some areas. And basically, if you were trying to run a health system, you better to have a monopoly, because then you can direct your resources optimally. A market's probably not the thing to have, in the sense that it's not really a commodity that people want to buy. If they can avoid buying it, they will. They don't want to get sick. And it needs universal health insurance so that we all pay the same, and we get what we need, not what we can afford. So it doesn't become how deep your pocket is, it's how sick you are. So I must admit, I'm a great believer in universal free health insurance, and that's being progressively undermined towards an American model. If you look at the main driver of health policy in Australia, it's not how to run a good health system. It's how to shift the costs to somebody else. Now, there's really 5 players in this. There's the federal health department, there's the state health department, there's the private health insurers, there's Medicare, which is effectively federal, and there's the patient. So each one of them is trying to get, I guess you could call Medicare and the federal government the same thing, but they are each trying to shift the costs onto some other aspect. They don't care what the total cost is, as long as they can shift the cost to someone else. So this is very inefficient because they're happy to take inefficiency as long as they're not paying. And this has resulted in things like, well, the general demarcation is that the hospitals are state and what happens out of hospitals is federal. Although that's not quite true either, because hospitals in the home are growing, and that's because the state is trying to minimize the number of people in hospital by subsidizing nurses to run around and discharge people more quickly to get them out of hospital. So there's a hospital in the home thing, which is now becoming keeping COVID patients at home in order to save money. And that's now a really growing area, which is still state. So when the federal government unlocks, the problem goes to the health system. It will be borne by the states largely. And I don't know how much that's in Morrison's thinking, but the problems won't really be his. If you look at just simple examples, they used to have outpatients. If you went to the emergency department, you went to outpatients afterwards. They abolished those, although they were very cost effective and they were good for registrar training. The registrars did most of the work. But when they closed them, the patients had to go to the specialist rooms, which is much more expensive, but the federal government, the private health insurers and the patients paid for that. The state didn't, so it was a cost shift. When you go to emergency department, they give you 2 tablets and say, here's a script for the chemist, and they save the cost of the rest of that script. But of course, your inefficiency is you have to go to the chemist and get another script, and it all has to be dispensed again, and the total cost is much higher. So we have this cost shifting, and the federal government, for its sake, has run Medicare down. Medicare was set up paying 85% of the AMA fee. It now pays 46%. So the GPs have taken a 50% pay cut over the last 30 years, really, in real terms. And that, of course, means the poor people can't afford it. The doctors tend not to do Medicare. The patients go to emergency department. And the cost of an emergency department visit is about $190. The cost of a GP visit at AMA rates is $84. The cost of Medicare rates is $46. And if the GP isn't accredited, it's $21, right? So the costs are being pushed to someone else. So the whole health system is about pushing the costs to somebody else. Now, this means when the stress happens, there isn't capacity. These states have run down the hospitals to the maximum extent, and there's blocks for ambulances. Long before COVID, they had no hospital to go to, they were diverted. So now there's a COVID problem, and the government the state government has ramped up hospital in the home to try and keep people there, and they have quite elaborate protocols now to for how long people stay at home. And the hospital in the home people, of course, are no longer discharging. They're no longer discharging as many patients to the hospitals in the home. Hospital and home staff are being used on phones, and they have a protocol to phone people. Some of them are testing them in home, they're swabbing them, and some of them are ringing them every day and saying, how are you going, how are you going, and watching for the red flags, you might call. So if they've got an algorithm, in other words, you bring them up and then they're classified by their risk of hospitalisation, the ROH, and their vaccination status, social factors like health literacy, whether they live alone, whether they've got a lot of kids, risk of violence and abuse. The double vaccinated, if they're double vaccinated, they're low risk, regarded as low risk. Their mental health, and they're provided with a pulse oximeter, which measures your oxygen. And basically in COVID, you can get bad lung disease and your oxygen can fall without you realizing, and people can get very sick. And then, of course, once your oxygen starts to fall, you can get very sick very, very quickly. And then, of course, you call an ambulance. And at the moment, the ambulance system is totally overloaded. And there was an article in the Saturday paper yesterday about that. So the system is really at breaking point. It's the federal government is throwing a lot of money at it. They're putting normal patients, if you put them that way, into private hospitals. Patients who are not COVID are going into private hospitals, highly subsidised. The federal government subsidised private hospitals early in the pandemic when they expected lots of cases. They were basically emptied and paid to stay empty in case we needed them. So the government at a federal level is throwing a lot of money at the problem, basically, so that you can't see the fundamental problems within the health system and the increasing privatization of everything and the running down of Medicare. Really serious health problems that are being swept under the carpet, I believe, by sort of what we say, random grants might be a way of putting it in terms of the federal government's policy. The key point about the lockdown is, and I think this is probably the message that's the take home from this talk as a whole, is that vaccination really can't cut it alone. And there's a graph which I want to show you. And just a second, I'll see if I can do this. Technology. Hang on, I can't share it. I've done something wrong here. How do I show you this graph?
Is the green button at the bottom of the screen?
Arthur, I will do it for you.
Thank you. I've tried to press the button and I've pressed the green button and it doesn't come up. Can you put it up, Kathy?
Yes, I can.
That would be very helpful.
Thank you, Kathy.
Let's see. I'll get it. I thought I just opened it there, but
I understood it conceptually. It's just when you have to do it, it's not quite the same, is it?
No, it's your first time, so no worries. Just 1 second, and I'll find it myself.
Right. Well, the graph.
Right, I've got it. Now I'm going to switch.
Lock my face out and put the graph up, and I'll just keep talking.
Yes, all right, dear. Where is preview? There it is. Okay, share. Is that the one you're talking about?
That's the one I'm talking about, yeah.
Okay.
Now, this is a graph of what will happen to the numbers of Delta patients. Now, the R number that you see at the top there, it's a Delta variant, is a type of COVID which is more infectious than the previous ones. It's a general property of viruses that the more virulent one, that is to say the one that gets from one patient to the next fastest, will outcompete the viruses that get to the next patient more slowly. So the Delta variant is more infectious, right, or more virulent, as they call it. That R number is the number of patients that come from each patient. So if one patient produces 6 other cases, that's an R number of 6. Right? Now, if nobody comes in contact with anybody, right, the maximum lockdown, if you look at the blue line down there, R number is 1.2. So each person infects 1.2 people. That's with only public health measures. In other words, you keep people from getting anywhere near anybody else as much as you can, and not many people get next to anybody so that the people don't get sick. If you then add vaccines, which means that they transmit it less and carry it, you have less cases, this muddy khaki one goes down there. The R number gets less than 1. Once the R number is less than 1, the total number of cases will decline. Once the number is above 1, each case will infect more than one other case, and so the number of cases will slowly rise. And the size of the R number is how steep the rise is. And you can see it always gets more and more steep because it's a geometric progression. 2 becomes 4, becomes 8, becomes 16. Each time it doubles bigger, right? So that is with public health measures. Now, if you have vaccines only, in other words, you let people breathe on each other, which is what it boils down to, even with 80% of the total population vaccinated, if the vaccine is 60% efficient at making people not get sick, the graph goes up like that. And if you see the difference in vaccines only compared to public health measures, if you've got 80%, 85% of the total population vaccinated, you've effectively got 15% of them not vaccinated, right? And 15% is quite enough to transmit to people. So someone goes out there, 15% of the people he or she meets will be able to be infected, and some of the others will be infected as well, although they won't get sick. You get a massive increase. The R number goes up to 2.9. If you've only got 64% of the population vaccinated, the R number becomes 3.7. So you have a very rapid rise. So the people who think that vaccines can replace public health measures should look at this graph and see that it is an absurd proposition. Right? You need public health measures and vaccines. And of course, you'll see these two graphs. One's at 64% vaccinated, the other one's 85%. They still go up very steeply because there's still a lot of people not vaccinated. Now, if we look at Australia's vaccination rate,
is there another graph that you want shown, Arthur?
there's some numbers. I'm trying to find the right. Yeah, here we are. Oh dear, I can't show. Kathy hasn't got this one. I just talk about Australia's vaccination rates. Then it doesn't matter. Basically, Australia's vaccination rate is 93 doses per 100 people, according to the WHO. In other words, we've had 93 doses for each 100 people, which means on average, we've got less than 1 dose per person. 71% of the over 16s have had 1 dose, but that's only 57% of the whole population. You can't ignore the under 16s because they're great little spreaders. If the kids go off to school, a lot of them will get infected because they'll be socially probably more in contact with each other than the average workplace, and they'll bring it home. If you've ever had a kid and the kid's gone to daycare, the minute the kid goes to daycare, the parents get every cold in the whole country because the little kid gets it from the other kids and brings it home. And of course, it's an intimate relationship you have with your kids. So if you've got an isolated home, but your kid goes to school, you have a wonderful conduit for the virus. So that when you say 71% or 70% of the over 16s are vaccinated, you've effectively got 30% not vaccinated, and then you've got 57% of the population as a whole not vaccinated, with the kids spreading it. So it's very irresponsible. It's been 43% of the population have had no vaccine. Now, it's simply not enough people. We've got 46% of the over 16s vaccinated, 46%, which is 37% of the population have had 2 doses, which means 63% have either had no dose or 1 dose. Now, that is not enough protection, quite simply. And if you go back to the previous graph, or you remember the previous graph, the idea that a vaccine can replace public health measures is absurd. And even with very high vaccination rates, you'll still get a big climb. And I think we have to go a bit longer. And of course, the thing stopping vaccination really is, or the thing that's stopping us locking down, is that the government has abolished JobKeeper and JobSeeker at a realistic level. And the people who are most affected are the essential workers, who of course often live paycheck to paycheck and haven't got any money. So effectively, it's the government's unwillingness to subsidise it for a bit longer, and they want to open it, which saves them subsidising and supposedly helps the budget. The cost of treating somebody is horrendous. The cost in intensive care of a person is extremely expensive, not to mention that they may die. And even if you look at the cost, it's extraordinary. And the labour intensiveness. And I mean, you've got a 10% long COVID rate, so that if somebody gets sick with COVID, 10% of them will have ongoing problems with their lungs, sometimes with their memory, with depression. The idea of simply saying, oh, well, we've got enough intensive care beds, we've got to open up sooner or later. We should wait until the vaccination rate is absolutely as high as we can. I think we should wait until the kids are vaccinated too. And I don't think that's impossible. If we can vaccinate 1 million people a week in New South Wales, it'd take 4 or 5 weeks to get all the people who are willing to be vaccinated. My own view is it should be compulsory. When I worked in New Zealand, I was going to work in Dunedin Hospital, and they said, have you had all your vaccines? And I said, I think so. Where's your certificates? Where's your record? 20 years ago, 30 years ago, maybe. And they said, no, well, if you better have them all. So they just said, well, no vax, no job, basically. And that was regarded as 100% normal. And this idea that it's your civil right to not to be infectious is absurd, really, I think. And if someone said, oh, you don't have to wear a seatbelt if you don't want to, it's an invasion of your private space. Well, that argument was had in the 1960s. And in 1970, Victoria was the first jurisdiction in the world to make seatbelts compulsory. It's all been accepted. The fascists haven't marched any faster because seatbelts are compulsory. So the idea that it's the thin end of a wedge, I think, is a nonsense argument. Yes, it does involve some personal risk, but the right to infect somebody is much less important than the right not to be infected. We had this argument with passive smoking, but this is much, much worse than passive smoking in that it's not transient. It's a permanent long-term infection that may kill the next person. So, and of course, the masks reduce spread of small particles of liquid by about 85%. So the masks mostly help people who are infected not spread it to other people. The spread back the other way is only reduced about 15%. If it's in the air, it won't stop it coming in as well as it stops it going out, because the droplets all end up inside the mask. So masks are very important also and mustn't be ignored, but staying at home and staying distance is very important. So this rush to open things is very worrying. I think, if you look at the political situation, I think it's the big end of town telling the government what to do, and I think it's an extremely foolish thing, and will end up in a disaster. I think we'll overdo the capacity of the health system for basically an unwillingness to hold on a bit longer.
Okay, thank you very much, Arthur. I've got a lot to think about there, and it's a really, direct bit of information that people have to deal with. Can I now ask Ian, Professor Ian Hickey, to switch on your microphone, Ian, and we'll hear your views.
Yeah, and thanks for the opportunity. Normally, I'd be coming to you from the lands of the Gadigal people of the Eora Nation from my office at Sydney University. At the moment, like everybody else, I'm locked down. And it has become kind of interesting that mental health has suddenly appeared as the health reason to justify rapid removal of restrictions. As I wrote in the Sydney Morning Herald 2 weekends ago, the sudden interest in mental health is welcome, but the weaponisation of mental health for political reasons is not welcome. And I think we need to look at what has happened over the course of the pandemic in terms of mental health and where we are now. So back at the start of the pandemic, myself and my colleagues at Sydney University were involved in a lot of modelling of the potential impacts of the pandemic on mental health and on suicide and suicidal behaviours. When you think about mental health, there are two main pillars on which our mental health and wellbeing individually and collectively stand. One's personal autonomy, being able to go about your business, earn an income, be in good health, make choices about your life. But the other is social cohesion, the extent to which we can act collectively in our common interests. The pandemic represented a major threat to both of those, a major threat to job loss, to unemployment, to social disruption, to economic hardship, as well as being suddenly disconnected with each other. Face of most threats, most things that we're really scared of, we huddle together and we respond collectively. Certainly most acute stresses, bushfires, overwhelming events, disasters, people often come together and behave cohesively. However, the pandemic therefore represented a significant threat. And you can model the virus, as Arthur was just showing you, in terms of his R numbers. You can actually model the mental health impacts. You can model the likely outcome in terms of suicidal behaviours, presentations to hospitals, deaths, etc. And that's exactly what we did. More importantly, you can make recommendations to government, as Arthur was just showing for the virus, what you can actually do. So we were emphasising at the start that things that really mattered were what turned out to be called JobKeeper, increasing the amount of job seeker, supporting housing, particularly the most vulnerable, supporting not foreclosing on mortgages, providing the social safety net to really work. It's interesting, during the early phase of the pandemic, social inequity in Australia went down for the fastest rate that it ever had done in 30 years. We actually did stuff that we said it wasn't possible. Put homeless people in hotels, kept people connected to their jobs, didn't allow people just to become unemployed, to participate, at least for the start. Our recommendations to government based on that modelling is that JobKeeper in particular should have been continued not just beyond the September 2020 deadline as it was, and not just beyond the April 2021 deadline, but should have been continued throughout and should have continued right through to 2022 at least, even if modified in this exact form. Keeping people connected to their workplace is critical to social connection, as well as the income support that flows. Other areas in terms of education support for young people and other areas were not so effectively supported, and certainly support for casual workers, support for people who were not Australian citizens, support for women without assets often in casual jobs, often from non-English speaking backgrounds, was largely absent from those government programs. So while government did some things that were useful, it actually avoided doing other things, which would have been quite useful too. One of the things about the mental health modelling that we predicted is that the impacts would not be short term. They were never just due to lockdown. They're complex in the social, the economic ways in which I was just starting to describe. And they have their biggest impacts on young people, those with less assets, those with less opportunity. So these kind of threats, these kind of social difficulties that we faced exacerbate the inequities that we already have. And they hurt most those who are most vulnerable in the first place. The truth is, in 2020, beyond the JobKeeper, job seeker issues, from a specific mental health point of view, government didn't do very much. It was waiting for the Productivity Commission report. It was waiting for the Victorian Royal Commission. We and others lobbied hard to include things in the initial response, in the 2020 budget in October, in the subsequent budgets, to actually do a lot. In reality, only the Victorian government under Dan Andrews, which has committed $3.8 billion to mental health following its Royal Commission, is anywhere near the size and scale of what's actually required, at least at a state level, to get the process going. The Commonwealth has talked about $2.3 billion over the next 4 years of mental health, depending on an agreement it's currently negotiating with the states. So over the 18 months since the pandemic started, if you ask what governments have actually done for mental health, in terms of the economic bit, JobKeeper, job seeker supports for the first 6 months and then JobKeeper for 12 months, very important. Beyond that, not much, just awareness campaigns and hold each other's hands and sing Kumbaya and hope it all goes well. You know, we all pull together, but in fact, do we all pull together? Not really. As we've just seen in the Delta strain experiences in Sydney, those in southwestern Sydney have had completely different experiences. So those who are already more vulnerable, those who are already doing things tough, those living in much more difficult circumstances, many of those essential workers Arthur was just discussing, have actually had to go and actually continue to work, continue to earn a wage, continue to live in ways that the society has not been very sensitive to. And then they've had challenged about whether they're really behaving as Australians. Are they really pulling together? You know, I've spoken to a lot of people from Muslim backgrounds, from non-English speaking backgrounds, who felt really harshly that they have been blamed for the exacerbation of the situation in recent times, when in fact, as people will recall, the outbreak occurred in eastern Sydney, wasn't contained, but has had its maximum impact on people's lives and deaths and disruption in Western and Southwestern Sydney. And like many, many other health issues, it's hit hardest those with least resources, with least assets, and exacerbated the health inequalities. So suddenly, about 3 or 4 weeks ago, in New South Wales and elsewhere around the country, up pops the chief psychiatrist. Up pops the, we've got to end all this for the mental health consequences. We've been going on about the mental health consequences for 18 months. Nobody's really been listening, but suddenly it's at the top of the agenda that it's the reason We've got to end all this and end it in a big hurry for the mental health consequences and for the kids who are being affected. The kids are being affected. Disruption to school, disruption to education, disruption to social development, the wider for all of us disruption is really important. I'm the first to say that. But there's also then what are the risks associated with rapid de-escalation of the public health measures. And when you look at who, I'm intrigued in the public messaging. I've written also in the Herald about the extent to which white Anglo-Saxon males dominate the message, sending the police, sending the defence forces, sending people in uniform to tell you what to do. And often the language of our chief officers, I need you, and if it goes wrong, it's your fault. And that finger blaming, often at people in southwestern Sydney. If you don't stay home, you're going to send the police and the ADF and the curfew and helicopters over the top, because that's the problem. As distinct from what you really need is communities to act collectively and together and to understand the cultural and other differences that actually exist and the struggle that really exists for multi-generational families living in very different circumstances from many other people, including myself, who live in much more privileged circumstances. And then who's really at risk if you rapidly remove the restrictions that we actually have in place before the vaccines arrive? Now, before the vaccines arrived, of course, if we'd all been vaccinated much more quickly, we'd be in a different set of issues long before. But clearly, the vaccine supply, remember that it wasn't a race, was a major problem. But also who's had access to the vaccines, even if they had arrived. The apartment that I normally reside in Sydney is right in the middle of the Alexandra Waterloo, the Waterloo Towers that have been shown on the news in the last 24 hours. How it is that those groups of people have not had access to vaccines up to this point, some of the most vulnerable people in society, clearly at most risk. You may or may not know that people with mental health problems, particularly severe mental illness, psychoses, and severe depression, if they catch COVID, they're much more likely to be hospitalised and much more likely to die. So when we talk about who's really at risk, many of those people with pre-existing mental illness already have other issues. I love this idea of underlying health conditions. 41% of the population at least has other underlying health conditions. And if you die, you're one of those people who die, but you had an underlying health condition, somehow it doesn't matter so much. Well, of course, those people with underlying health conditions are not only likely to be older, they're likely to be poorer, they're likely to have other comorbid conditions, they're likely to have mental health problems and substance abuse conditions. So we've entered into this weird discussion about the value of life, depending on whether you have an underlying health condition or not. Now, of course, those who don't, who tend to be younger, who tend to be wealthier, who tend to live in better suburbs in a particular way, perhaps are more anxious to get back to their jobs, their lives, their unrestricted travel as they would like, without much consideration for what might be the impact on everyone else. Who is going to get sick? Who is going to get overwhelmed? Who is going to die? Who needs to use the hospitals in southwestern and western Sydney that are much more under pressure than those on the northern beaches or in eastern Sydney or in the regional areas at the moment? So there is a lot going on that's very hard to explain as to why mental health should get dragged out. If you're interested actually in the mental health of people, what you're interested in is the fastest possible but effective health solution to get our society back to where it was. We're lucky in Australia to some degree that we've avoided the health disaster that did happen in Europe and the UK and in North America. And particularly interesting to look at the UK and North America, societies that have lost their fundamental social cohesion, that couldn't respond. And of course, in the Trump years in the United States, a complete disaster, and still can't effectively respond to the Delta variant. But who has been most affected by that? Which groups of the population have suffered the most in those particular kind of areas? We have, as I say, been lucky to avoid that. But in terms of the social and economic effects of the pandemic, we see in Australia that, as predicted, the effects have mainly been on those who actually have not been so effectively supported by government, who had less assets, who were in casual work, who were younger, who were often from migrant backgrounds, non-English speaking, etc., on an ongoing basis. So at this point, if you're really interested in the mental health of where we all go, yes, we've got to find a way to effectively, but slowly and responsibly, gradually remove restrictions in an effective way that does not put those who are more vulnerable at greater risk and allows that to happen. Clearly sitting behind that are two aspects. One's access to vaccines and the proactive nature of that. The government chose very much to go down an unusual path for vaccination. very strong reliance on private providers through aged care, on GPs, and only partial providers on state-based hubs. This is contrary to all of our previous work in national vaccination work, where if you go through the states to start with and then require the states to make contact with those more vulnerable populations, the more vulnerable populations, guess what? Get vaccinated much more quickly. We wouldn't be suddenly staring at the towers, the housing towers in Waterloo and Alexandria tonight and wondering how it is that those people weren't further up the queue. You wouldn't be wondering why in southwestern Sydney the vaccination rates in non-English speaking communities and other would be de-emphasised. All the issues that Arthur discussed about access to healthcare, if you use a private model or even the general practice model that we have, favour those with higher health literacy, with higher economic capability, with better access to healthcare. They've been prioritised. So there are many examples where, unfortunately, the way that Australia has approached many of the key issues associated with the pandemic have only exacerbated those various health inequalities and social inequalities that existed beforehand. And from a mental health point of view, even more importantly, they remain the issues. So any notion that we have to rush to end quarantine to save people's mental health, it's a nonsense. It has been a nonsense from the start. And any sense that everyone individually can take care of their mental health. The famous thing that has become an Australian kind of another awareness campaign, which is kind of nice in ordinary times, are you okay? Should have this year been, are we okay? And the answer would have been, actually, we're not okay. We're really struggling. All of us have actually struggled because we're disrupted to some degree and distressed and somewhat disorientated by the pandemic. But collectively, if you look at how we've responded as a nation, we're not okay at all. There's a national disintegration, state against state, Eastern Sydney versus Western Sydney, Anglo-Saxon older English entitled versus non-English speaking, migrant sort of backgrounds, you know, those of essential workers versus those in careers and those in their professions in various ways, and now a pretty clear division of a fierce economic drive. I had the pleasure of doing a podcast this week, Minding Your Mind, which I'd like to advertise to all of you. Minding Your Mind, which I do with James O'Loughlin. We're talking about Ross Kittens, the economist, this week. This notion that the economy is a holy grail that we all must worship. Actually, the economy exists for us, not the other way around. We don't work for the economy. The economy needs to work for us. And when people are asked to trade off the economy versus their health or dying, guess what? They tend to choose staying alive and worry about the economy a bit later on. And what you're seeing, of course, is play out in Western Australia and in Queensland and South Australia and Tasmania. That's a large part of the country, actually, where they have the situation still relatively under control. And the ACT fighting ferociously, even though it's landlocked in New South Wales, to keep the Delta variant under control long enough for for vaccination rates to go up, so they don't necessarily have the same degree of infection and hospitalisation and death as New South Wales and Victoria now face. Guess what? The population chooses that. The population doesn't worship the economy. It wants to stay safe if it can, up to a point, over a reasonable period. No one in those states thinks that's forever. It's not la la land. It's not forever. Everyone knows that eventually the nature of the virus. I had the pleasure of being on a Academy of Social Sciences a webinar recently with Peter Doherty, the Nobel Prize winner. He said, look, the Delta variant's going to end up being like chickenpox, okay? It's a very infectious virus. It spreads. That's not really the question. The question is, have you got the situation under control? Have you actually dealt with the most vulnerable? Are those who are most at risk seriously protected by vaccination and then by continuing public health measures as appropriate? Sadly, and I think we've seen this play out this last weekend, I, for the life of me, can't figure out why those in the housing estates, why those who are most at risk weren't prioritised a lot earlier, why those with chronic mental health problems weren't prioritised a lot earlier, why the state systems weren't reaching out to those people, not relying them to come to hubs, not to get themselves online, if you can work it out, and get yourself to Homebush and figure it out, and whether you really were prioritised or not, that the most disadvantaged way, people would somehow find their way through that system to vaccination. Or we're in the circumstances where socialisation is easy, where it's not easy in those particular situations. So I think what we've seen, again, is that great Australian laziness. What could possibly go wrong? And what we've seen is, what can possibly go wrong? when you don't proactively act cohesively and you don't reach out to those who are most at risk. Because when they're at risk, guess what? We're all at risk. The notion that you can act individually and protect yourself or your family or those you don't wish to know because they live in a different part of the city or they come from a different cultural background or they suffer from mental illness or they're poor or they're disadvantaged. Guess what? When they're unwell, we're all unwell. And from a mental health point of view, I think that's my overarching message too, is that actually I was asked at the start of the pandemic, did I think Australia's social fabric was intact, that we would act collectively? And a rather kind of, trying not to be too miserable about it, I said, look, I think so. We kind of like mateship. We kind of pull together. We generally do well in natural disasters. We're generally fairly skeptical of central government. We're generally kind of cohesive. But I think at this far in, you've got to ask yourself, have we actually done that well? And I think actually the answer is not as well as we would have liked. And if at this point we somehow use the excuse of mental health problems to justify putting many, many more people at risk that need to be at risk, and particularly that we put at risk some of the most disadvantaged members of our society, then I think we really will have failed. There's clearly a large push from that. It's attributed to the business community. It's attributed to certain forms of economics, but that kind of economics, worshipping that economic God, it's a false God. As Ross Giddens says, the economy exists to serve us, not the other way around. Our mental health and well-being is us. We need an economy to support it, but actually we need to protect it. So I think the issue is at the moment, actually the safe and clear way to go is not to read into the Doherty report anything you like. The Doherty report actually is quite conservative if you get into the detail. It's not an excuse. 70% isn't 70%, it's 56%, as everybody knows. There's a lot to be done with kids. People aren't going to rush out and put their kids at risk and put others at risk. But more importantly, not more importantly than that, but equally importantly than that, is there's a whole lot of vulnerable people at risk whose voices are largely absent from much of this public discussion. And I think events like the one that we're participating in this evening need to continue to say that really matters. And their mental health and well-being is our mental health and well-being. And we all need to take responsibility for that. Thanks.
Thank you very much, Ian. That was really, really brilliant, I think. And I think it's a big challenge as we're all going to go into this next 5 weeks. The pressure will really be on both ways, I think. So we'll go to the Q&A. The first question I got was to Arthur, I think. With custom-built facilities, historically speaking, people were able to recover together and socialise together. Hang on. Right, sorry. Arthur, what do you think about custom-built quarantine and hospitals for this COVID pandemic? Considering Australia does have a history of building such from the 1830s to deal with the many pandemics we have had. In fact, facilities in New South Wales, Queensland, Victoria, and WA still exist, have been fully restored, include accommodation, and are now tourist attractions. Could they be used, in your opinion? So over to you, Arthur.
Sorry, I wasn't unmuted. Yeah, well, the Manly quarantine station's lovely historically, and it has 3 levels, steerage class, middle class, and upper class. But the facilities are, 150 years old or whatever it is. I think to simply say to people, well, go for it, team, might be a little primitive. But at a serious level, I think the idea that we simply took big hotels and threw money at them and said, yippee, we've killed 2 birds with 1 stone. We've made the rich people happy. We've kept the hotels open, and that's very good. They're not designed for quarantine because the airflow is not isolated. There's not HEPA filters between rooms to make sure that the air is got all the particulates out, which is what you really need. I mean, you're much better to have a tent city where all the tents are further apart than you are to have a hotel in the center of town, really. I mean, there's no reason why we we've ignored infectious diseases for a very long time because they haven't been such a huge problem. And I've worked a lifetime in medicine, and I've never really had to worry about serious isolation. There was the odd ward which had an infected person, or the odd person who needed reverse nursing where they had no immune system and we were going to infect them. But it's been a very small part of the hospital system for a very long time. But a quarantine station needs to be built as a purpose-built thing with isolated air pockets, really, and not too much contact between individuals. Then all the people at quarantine are not the same. If they come off the same plane, doesn't mean they're all infected and they can all just socialize. Some of them are infected and some are not. Even on the ship, some are infected and some are not. And you don't want to have the quarantine station infecting the lot, saying, righto, you can all wander around and infect each other, and then you'll all stay till the last one gets over it. That's not what you do. You have to isolate them by the groups that they were in, which are infected or not infected, and keep them for the incubation period. I think it's a disgrace that the government hasn't done that in all this time, and all those people are stuck overseas. And it's typical of the government. Now they're getting the private sector to fill it in 18 months later. I mean, it just says the way the government does everything now. It's all for profit, and we don't do anything if we can possibly avoid it. And I think it's an indictment, particularly of neoliberal governments lately, but this one in particular.
Thanks, Arthur. I don't know if you want to make a comment on that, Ian, but I've got another question here, which brings out some of the other issues, I think. This is from somebody on the Consortium News audience. Ivermectin. Why don't we act on the data out of India that showed the success of ivermectin treatment and then the increase of hospitalizations after the government banned it in favor of vaccines? So, we're dealing here with the controversy. So who would like to sort of have a go at this problem we're having in the whole debate?
You want to have a go, Ian?
I was going to leave that one to you, Arthur. But I'm happy to say I read. I'm a person who reads the stuff regularly, and I take quite a lot of interest in what others have to say. I'm afraid to say I think that person's information is not accurate.
I'd agree with that.
Yeah.
And I think it raised an interesting thing. Misinformation about drug treatments, about all sorts of things at the moment is rife. What fascinates me is the extent to which people believe it. Like, running off to believe things. I mean, I understand the distrust in government, generally speaking. There's a sort of an aside to all of this. What I have thought is unhelpful during this particular period, I was just talking about the politicisation of mental health. The politicisation of our chief health officers, of health officials, of health advice, I think has also been very problematic. What we don't have in Australia is actually things like the National Institutes of Health. I mean, Dr. Fauci in the United States, the National Institutes of Health. National Institutes of Health is actually separate from government. It's not a government. He's a government paid official, but his governance is separate. What we found is chief health officers standing up next to premiers and things, all the prime ministers all the time, and sometimes a bit hard to tell because, it confuses the public if the health advice from one chief health officer is completely different to another. It's fine to open up. It's fine not to open up. It's fine to have this vaccine. It's not fine to have that vaccine. That creates real problems. And I think that creates the environment of furthering the distrust that already exists in the wider world. Obviously, that something's been fanned hugely out of the separatist politics of the United States and elsewhere in the world to distrust reasonable medical advice. The reasonable medical advice about ivermectin at the moment is forget it. The reasonable advice about vaccines, we're lucky. And just people, I think, are a bit forgetful. If you go back a little more than a year, there was a great, and I sat through Academy of Science meetings, Academy of other meetings. There was a great deal of anxiety about whether we would have any effective vaccine. Most vaccines fail on the way to production. The fact that we have actually a number of different vaccines, all of which are effective, they are different in their side effect profiles. No vaccine's ever been invented that didn't have side effects in a particular way. They've been closely supervised. The overwhelming benefits to us all of vaccination, which is what public health and vaccination is all about, it is about protecting all of us in a particular way. It's kind of interesting. So the distrust of reasonable medical information and the promotion of nonsense and really harmful medical misinformation is really difficult, really, I think reflects rather sadly on the world that we do live in. And I think one of the things we're going to have to think about in Australia is how do you rekindle trust in actually good medical advice? And I think actually we need to see a movement towards greater independence of the medical advice from the machinery of government, the machinery of politics, so that people are more trusting, again, of the medical advice, which is advice, it's not the decisions, from the political decisions that people make as the elected representatives of us all.
Okay, thanks. There's another question to both speakers. Are we to assume that this recent concern with mental health as an urgent priority is coming from the government that is starving people, especially those who have low income and can't work from home, to starve them back into the workplace? Is that a reasonable read?
I don't think it's aimed at particular people. I think it's part of a basically ideological debate where, you know, people have worshipped the god of the economy, whatever that is, versus this idea of, you know, and other really interesting ideas that sit behind it. Do you remember we couldn't afford it? The debt. Do you remember the debt? You know, then suddenly last year, forget the debt. I was again very lucky this week to be on a webinar with the governor of the Reserve Bank. Debt is just not a problem. Australia is a very functional economy, longer term. There are issues. The reason you have what we have is when you have a crisis, you need a government to spend money on the stuff that matters: healthcare, supporting jobs, supporting it while we do everything we can to ride out that crisis. So I don't think it's actually sort of, you know, something you need to be paranoid about. It's not aimed at a particular group. It's ideological, basically. You know, and that behind that, there are certainly businesses, and let's face it, there are lots of businesses that have been really severely affected. You're in hospitality, you're in tourism, you're in a number of other creative arts and other industries. This has been a disaster. So there are lots of small businesses and other businesses and lots of bigger businesses in the airline industry and others who are in danger of collapsing, you know. So clearly, they all have an interest in the economy opening as soon as possible to get back to where they were. Of course, there are others. I'm part of the higher education industry, which no one seems to care about. And in fact, you know, up to 40,000 jobs have been lost in higher education during this particular period. Government doesn't really like that. I had a fascinating, to mind me sharing with you, I actually filled out the forms last year for JobKeeper on the basis that we in the university sector should, because massive loss of overseas students, and I have a nice secure job, but we were all facing the situation. Only to be told by government, you're not really a worker. You know, university academics, forget it. You know, what useful work did you ever do? You know, you don't wear a high vis vest or a hard hat. You know, you're trouble. You know, so the ideology of these things has run through many aspects of the pandemic, and I think not to our national benefit in particular ways. So I think the issue at the moment is and anyone who's looked at the economics of this, the better the health outcome, the better the economic outcome. If you screw the health outcome, if you mess up the health outcome, the worse the economic outcome. So the tricky thing for governments, and I wish we had a more sophisticated debate in Australia, a more serious if the national cabinet was actually a national cabinet, a serious national consensus. Of course, we need at some points to move to less restrictive environments. But how do we do that in the safest way that puts the least number, and particularly the least number of vulnerable people, at risk as we go forward?
Thank you very much, Ian. What about your comment on that question, Arthur?
Oh, I agree with Ian. I mean, that's exactly right. This ridiculous ideology that you can run the economy and it doesn't matter what the health system does, when you've got thousands of people dying at vast cost, it's frankly absurd and very callous. And the idea, as Ian said, last year we couldn't have any debt at all. Then we've got the biggest debt we've ever had in history. And then we're saying, oh, now it's too big again. You know, we have to cut it back again. So it's very much ideological, I think, you know, that we mustn't have debt because, you know, it's bad to be in debt. We basically have to keep the country running. And if we keep the people at home who who have to stay there, and I, the way they've destroyed the higher education sector is vandalism beyond belief, really. But it's again part of this thing. The only thing that matters is money. Knowledge doesn't matter. You can always get a cheap academic because there's so many of people educated. So we don't care that if as long as the education system makes a buck, we don't really need to know much more than that. It's an arrogance of management. I think it came from the idea that the only thing that matters is whether you can manage something to make money, and if everything else is of trivial importance. And if you can make money, everything, so you don't need experts. You just get one in and put out a tender, get in a mate. It's this lack of respect for knowledge and the idea that the money is the only thing that matters will not cut it. If you make the wrong policy decisions in health particularly, and this is the one we're talking about now, if you make the wrong policy decisions, a lot of people die. If you think that's going to help the economy, then you really don't understand things. And I think the hubris of the Morrison government that thinks if you put out enough press releases today that they've forgotten the one yesterday and the day before, and you keep this stuff going, eventually people will forget because you've repeated it so much. Well, you might be able to influence perceptions. But if a lot of people start dying who didn't have to, you can put out as many press releases as you like. The people will be very angry and quite justifiably. And that's, I'm afraid, where we're going.
Okay, thanks, Arthur. Maybe I can bring it back to the real situation we're facing in Sydney and New South Wales. So now it's September 19. Come October 25, the government seems to be saying we will be lifting the lockdowns. We will have, masks. We will have some limits on numbers meeting, but basically that's it. So can you see any prospect of that basic decision being adjusted, changed for the better in terms of the problems you've both talked about? Rising numbers of cases in hospitals, people's fear even of going out. Is there a scope that you see in our processes in New South Wales for that?
Yes, because you see it already. So, I was talking to colleagues in the Northern Rivers just early last week. Within a day, Lismore was shut down again. So I think what's going to happen here is you're going to have the big kind of, we've somehow set you all free to save the economy and save the business and get the kiddies back to school. And then you're going to see actually region by region, place by place, it's not nearly as simple as that. And depending on what's happening around infection rates, parents aren't going to simply rush their kids back to school either, unvaccinated kids in particular ways, particularly teenagers, So yes, schools might be open, but how many kids are there? So I think, and then of course it'll be the summer holidays 3 weeks later, and the kids will be out of school actually again. So they'll have opened the schools, but the kids won't be at school. If you're serious, you'd probably cancel the school holidays, but it's a bit like cancelling Christmas, really. It's not going to happen in a particular way. That's not really what's going on. So I think, we live in a weird kind of world of press releases, of media cycles. What's going on seriously behind that is the extent to which the public health systems are actually working, are coping, are supporting particular communities or not. What happens in the hospitalisation rates, we haven't mentioned this evening, but the immunisation rates, vaccination rates amongst Indigenous people remain incredibly low. They're incredibly vulnerable communities. They're going to be decisions made that say, oh, look, it's open, but the little bits are shut, or we haven't done that. So I think what you're going to see is the hoopla out of New South Wales, now the national government that, we're living with COVID, it's all fine, we've rescued the economy, jobs are back, stuff, blah, 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 out of recession. But actually from place to place, and I think what would be interesting is compare the rhetoric in New South Wales and Victoria, because in truth, probably pretty similar things will be happening about trying to manage the gradual reduction in areas. In the other states, one of the problems is actually encouraging people to get vaccinated before they have significant Delta outbreaks or exposures in those states. but they've obviously still got some time on their hands, so they will use border restrictions much more ferociously. I think Mark McGowan's made that pretty clear, and Anastasia Palaszczuk made that pretty clear. Works pretty well. People want to stay alive. It causes disruption, you bet. But, no one wants to get really, really sick. And, COVID isn't just the flu. If you're unvaccinated, you've got other health issues or whatever else, it's really seriously dangerous. So weighing up those kind of issues is going to be, and then the impacts on the health system, as Arthur's talking about. We don't have a lot of capacity in the health system. We saw this last year. The underinvestment in public health in Victoria really harmed Victoria. The bits that aren't there when you can't see them, they're not emergency rooms, they're not, but the public health infrastructure was seriously degraded in Victoria, and it cost them a lot. There's very little capacity in the health system, and particularly in the mental health system, in any of our states and territories. So we can't cope with too much more pressure than we ordinarily have. And a whole lot of other bits of the health system have been cancelled or put on hold or suspended in a particular way. So there are all sorts of impacts. So I think if you can wade through the nonsense, higher level rhetoric, I think what's going to be more important is what is actually going on in different communities at different kind of periods. And the real issue, which I wish the government would pick up, isn't 70% or whatever. It's getting to much higher rates. We're all much safer, when 90% of the entire population is vaccinated, including the kids. And also, it's 90% of everybody, not 90% of the northern beaches or 90% of, the wealthier areas or 90% of those with higher socioeconomic groups or 90% of those who don't have underlying health conditions. It's actually when it's 90% of all of us. Then you're in a different kind of situation of reducing transmission and, in that sense, living with COVID like we live with other really serious illnesses that we've been able to vaccinate against, plus, as Arthur quite correctly emphasised, with the appropriate other public health measures when there's an outbreak, and monitoring that very closely. I think the danger is, of course, the danger is everyone else interprets the government rhetoric to mean, you beauty, it's all off, and just resumes their normal life in a particular way. And other government messaging, which has been really unhelpful, that a lot of the dangers which are indoors with poor ventilation in certain situations, which are much more dangerous than on a beach or in a park or in other kind of areas, gets confused in the particular ways. And then you get really serious outbreaks, again, in disadvantaged areas, in workers in certain kinds of environment with people less autonomy and less kind of choices. So what worries me is who's going to be most hurt by a fairly laissez-faire approach to this whole problem.
Okay, thank you, Ian. Arthur, have you got some comment there?
No, I agree with Ian. I think the government's hairy-chested approach, we're going to open up and this is our timetable, and business needs certainty so they can timetable things, and we're not going to vary from our path because you need certainty. This is just hairy-chested nonsense. And as Ian said, they're going to have to eat away at the edges to try and stop this thing. And if they don't, I think, frankly, it's going to be a disaster. And all the submarines in the world won't distract from the problem we're going to have.
Okay, we're coming up to 5 minutes to go. I've got a questions come through on my phone from Stephen in the Blue Mountains. So he's saying, are we at this point able to think about the next pandemic? What have we learned really from this experience of these 18 months or 20 months that, we shouldn't repeat? And what should we repeat for the next one? And I guess we have to realize that, we've seen Delta. What about we see some other variant that's really difficult to manage, 12 months from now?
Well, this is where the great Australian, what could possibly go wrong problem arises. Again, just to mention the webinar I was on with the Academy of Social Sciences last week, everyone across that field, and this included economics, sociology, health, was saying, we've got to stop and reflect on what's gone wrong with this one. But the chance that anyone in politics is going to stop and reflect with what's gone wrong with this one is nil. We're going to run into a federal election, fixed, it's all fine. As you said, we're not out of the COVID situation. The way low vaccination rates are the situation in much of the developing world, it's highly likely that other variants will develop. And when they tend to vary, a proportion will tend to be more infectious than the previous one. And if they win, guess what? we'll be back in the same problem again. And whether or not the vaccines are as effective against new variants will be a huge problem again. So I worry that one of the issues is the great Australian kind of, well, it's Christmas, or what, it was a bad year, but let's move on. We won't reflect on what have been the governmental failures, the machinery of government failures. Perhaps most importantly, though, the social failure. What have we not learnt about the society that we live in that we need to do differently? I think the heroes of this pandemic, and so written in or quoted in today's papers, have been the non-government organisations, the community organisations, the local action. People who've actually done really sensible things locally have learned a lot. What we haven't been able to combine that with is sensible machinery of government, particularly at the state and federal level in particular ways, so that we do actually act more cohesively, in a more responsive way. Of course, we have the luxury of geography, being an isolated island at this end of the earth. We tend to get to see what happens first elsewhere, but we haven't necessarily learnt about ourselves along the way. And to pick up Arthur's point, the hubris is unbelievable. Best in the world. And what have we been? We've been front of the queue, best in the world. Aren't we lucky? Boy, we made a few dodgy decisions along the way and errors. And to be fair to governments, who wouldn't have made some errors along the way? But really, preparedness, we don't learn. We had pandemic sort of scenarios before. We hadn't done them for about a decade. We weren't really prepared. We hadn't really had the machinery of government in place. So the question's a really serious one. Will we learn? Because there will be, either in the short or longer term, repeating situations like this. They've been predicted, and we've had with SARS previously, we've had other particular types of things that have come close previously, and in the global world in which we live. The idea, the arrogance of the Europeans that the Chinese virus wouldn't get to Europe, and the arrogance of the North Americans. I happened to be in North America when Trump was going on about the China virus. Don't worry about the China virus. There was only 15 cases at the time. It'll die out. Like the arrogance of those particularly developed countries that somehow they'd be fine and wouldn't have to worry about the rest. They'd be able to contain the miracles of modern medicine would extinguish this bushfire really quickly. I think unfortunately the world went to sleep and found the bushfire in the morning and burnt the place down. I think we need to learn. It's a really serious question whether we have either the right leaders or the right mechanisms to learn what we need to learn.
Thank you. I think we'll go to the last question to Arthur. Is natural immunity from having caught the virus better or more durable than induced immunity from a vaccine?
Well, interestingly, there's been a paper on this which says that the vaccine does better than a previous infection, which is counterintuitive, really. You would expect the natural immunity to be better. And they're saying that even if you've been infected, you should still get vaccinated. So that was an interesting point, and I think probably people need to know that.
Okay, maybe there's time for one more. This is from George. Is there any effort underway to collaborate with the Russian researchers who are developing a vaccine which actually blocks the transmission of the virus? That's a very technical question. I don't know if you've got it, but
my understanding is that the Russians haven't made their data available, and so the Western medical assessment system, if you want to put it that way, hasn't really had anything to work with and has therefore poo-pooed it. You could be more paranoid and say it's all political, but I think the lack of data, I think if the data were available on both that and the Chinese viruses, I think there would be people willing to look at it. And obviously they'd have to apply in terms of getting it approved by the relevant authorities. But the lack of literature on it in the Western press, what can you say? If you believe in transparency in order to make decisions, you have to say, well, if we haven't got any data, we can't say anything.
Okay.
I can't say transparency matters for all of this so much. There is actually work going on about all sorts of ways of interfering with the transmission of the virus, things you can squirt up your nose, things that might apply, and a number of the vaccines already clearly interfere with the transmission of the virus to a degree. So there's a huge amount of research going on worldwide. But Arthur's last point, transparency matters to us all.
Okay, thank you very much. I think we'll leave it there. It's been a really good discussion and your presentations were very, very helpful, I think, to our audience. So thank you very much, Professor Ian Hickey and Dr. Arthur Chesterfield-Evans. We can't do applause, but I'm applauding. And I'll just remind everybody that the Politics in the Pub is on again this Tuesday night at 6 o'clock, and the topic's quite different. It's called Energy, Moving to Renewables, another giant topic for our society. And the speaker is David Shoebridge, MLC for the Greens in New South Wales. So you're all welcome to come back for that. Thank you very much to Ian and Arthur and Kathy, the whole team here. Thank you very much.
Thanks, Peter. Thanks, Ian.
Thank you.
Thanks, Kathy.
Thanks.
Okay.